Hello, my name is Katharina Alamani. I'll be doing my presentation on bacterial meningitis. When it comes to bacterial meningitis, there are several types of bacteria that may cause this. There are several leading causes, but we are going to focus on Neisseria meningitidis. Now, when we speak about this, it is very serious and people do die in as little as a few hours. However, many people recover from bacterial meningitis as well. Those who do recover can have permanent disabilities such as brain damage, hearing loss, and learning disabilities. Some of the symptoms that we may see on the sudden onset are fever, headache, stiff neck, and there are often other symptoms such as nausea, vomiting, photophobia, sensitive eyes being sensitive to light, meaning altered mental status or confusion. And the newborns and babies may not have, or it may be difficult to notice, the classic symptoms listed above. Instead, babies may be showing slow or inactive states. They may be irritable, vomiting, feeding poorly, having a bulging soft spot, have abnormal reflexes, and we also see that typically the symptoms of bacterial meningitis develop within 3 to 7 days after exposure. Note that this is not true for the TB meningitis, but it is true for the one that we're speaking of, which can develop much later than the exposure of this type for the TB type. People with bacterial meningitis may be exhibiting seizures, go into a coma, or as we said before, it may be fatal for them. One of the earliest descriptions of meningitis that we can point to came from Thomas Willis, who described the patients with inflammation of the meninges with a continual fever. This was back in 1661. In the early 1800s, French and English physicians coined the term meningitis, combining meninges, which is the name of the brain lining, with the suffix itis, meaning inflammation. An epidemic of meningococcal disease in Geneva was first clinically categorized in 1805, and this was done by a general practitioner whose name was Vesuvius. The first outbreak in Africa was recorded in 1840s, but it wasn't until 1887 that Austrian bacteriologists identified the meningococcal bacteria as the cause of this meningitis. Next, we look at 1890, and this is when a procedure called lumbar puncture, or LP, was done on patients with suspected meningitis. Even today, LP remains the only way to accurately confirm a case of meningitis and reveal its cause. Hence the word bacterial, we see that the domain would be a bacteria. As we look further down in its classifications, we see the word Neisseria. This is a large group of bacteria that colonize the mucosal surfaces of many animals. Of the 11 species that colonize humans, only 2 are pathogens, one of which is the one we're speaking of, and the other can contribute to gonorrhea. So N. meningitidis, or meningococcus, is an aerobic, gram-negative bacterium closely related to N. gonorrhea, and to several typically non-pathogenic species of Neisseria. Now, the outer membrane of this is surrounded by the polysaccharide capsule that is important for pathogenicity because it helps the bacterium resist phagocytosis and complement mediated lysis. The outer membrane protein and the capillary polysaccharides make up the main surface antigens of the organism. So when it comes to pathogenesis, people spread these bacteria by sharing respiratory or throat secretions, also known as saliva. This typically occurs during close contact or lengthy living together situations. How people spread the germs often depends on the type of bacteria. It is also important to know that people can have these bacteria in or on their body without being sick. These people are referred to as carriers. Most carriers never become sick, but they can spread the bacteria to others. The current assumption is that high-grade bacteremia precede the meningitis, and that bacteria invade from the bloodstream to the central nervous system. Alternately, direct access to the central nervous system through dural defects or local infections are potentially entrance routes. The anatomical site of bacterial invasions from the bloodstream remains unidentified, but the experimental evidence suggests that the choroid plexus may be the site of invasion. Meningococci are found in the choroid plexus as well as the meninges, and the pneumococci infiltrate the leptomeningeal blood vessels in meningitis. These data suggest that several highly vascularized sites are potential entryways in order to cross the blood-brain barrier and to overcome sophisticated structures such as tight junctions. Meningeal pathogens may carry effective molecular tools. Streptococcal proteins such as CBPA interact with glycoconjugate receptors of the phosphorycholine with platelet activating factors, or PAF, of the eukaryotic cells. These promote endocytosis and crossing the blood-brain barrier. Meningococci PIL-C1 adhesins interact with CD46 and the outer membrane proteins that connect to the vitronectin and the integrins. Bacteria causing meningitis in newborns, most importantly the group B streptococcal and E. coli, which also cause meningitis, are also equipped with these adhesive proteins, allowing them to invade the central nervous system. Detailed knowledge of how bacteria activate and invade cells may allow to block these interactions and therefore to prevent disease progression. Although meningitis affects all ages and people all over the world are at risk of meningitis, young children are most at risk. The highest burden of disease is seen in some regions of sub-Saharan Africa, known as the African meningitis belt, especially recognized to be the high risk of epidemics of meningococcal, but also pneumococcal meningitis. Higher risk is seen when people are living in close proximities, for example, at mass gatherings, in refugee camps, in overcrowded households, or in student, military, or other occupational settings. Immune deficiencies, such as HIV infection or complement deficiencies, immunosuppressions, and active or passive smoking can also raise the risk of different types of meningitis. Immediate antibiotic therapy is imperative and must not be postponed by diagnostic delays. For example, waiting for a CT scan. Pre-hospital antibiotic treatment is advised in cases of suspected meningococcal disease, but depend on local resistance situations and the medical environment. Prior to treatment, a blood culture should be obtained since microbiological identifications of the pathogen is not immediately available. The initial choice of antibiotics is usually empirical. Factors to consider include regional antibiotic resistance rates, patient age, predisposing conditions, and resources. Another thing to add may be corticosteroids, which reduce brain edema, intracranial hypertension, and meningeal inflammation in the experimental models of bacterial meningitis. Other factors to consider. Severe headaches require generous analgesia, often including opioids. Anti-epileptic treatment is indicated if there are seizures also occurring. You can also help protect yourself and others from bacterial meningitis and other health problems by maintaining healthy habits. Don't smoke or avoid the cigarette smoke as much as possible. Get plenty of rest. Avoid close contact with people who are sick. Wash your hands often with soap and water. You can use hand sanitizer if this is not available. Cover mouth and nose with a tissue or sleeve when there is a cough or sneeze. Meningococcal vaccines help protect against this as well.